Great. Well, good morning, everyone, and welcome to UW-Madison Global Health Institute's monthly webinar. Thank you so much for joining us. My name is Kaylin Ostrowski, and I am the Associate Director of Strategic Partnerships and Development here at GHI. I'm delighted to welcome you to today's discussion titled Community-Driven Solutions to Maternal Health Disparities. GHI is a transdisciplinary initiative dedicated to advancing health and well-being for people and the planet through research, education, and collaboration. We coordinate, connect, and amplify efforts across disciplines and sectors to address the world's most pressing health challenges. Our monthly webinar series features researchers and practitioners from UW-Madison and around the world, highlighting the complexity of global health challenges and the diverse expertise needed to address them. Before we jump in, a couple of quick housekeeping items. First, we are recording today's session, and the archive video will be available on our website at ghi.wisc.edu. And we are monitoring the Q&A section, so please post any questions or comments for the panelists there. We will do our best to address as many of those as possible during the Q&A session. It is now my privilege to introduce our panelists. Each speaker brings a unique background highlighting the critical role of research and policy when addressing maternal health. We begin by welcoming our moderator, Niti Saxena. Niti is the Chief Technology Officer at Sehgal Foundation and has over 19 years of experience in development research and management across Asia. She has worked with NGOs, the UN, and international donors focusing on gender, women's empowerment, nutrition, governance, agriculture, and water issues. Her expertise includes independent program evaluations and mixed methods research, aiming to inform policy with grassroots evidence, including her notable work on a World Bank study on women and justice in Bangladesh and a Ford Foundation-funded feminist evaluation in India. At the Sehgal Foundation, she leads research and tech integration to enhance impact in agriculture, water, and education. Welcome, and thank you for joining us today, Niti. Next, we welcome Dr. Jill Denson. Dr. Denson is a research assistant professor at the University of Wisconsin School of Medicine and Public Health. She serves as director of the UW Prevention Research Center, where she engages researchers, community members, and translational partners in expanding community-based prevention research and health promotion to improve the health of women, infants, and families. Dr. Denson is passionate about maternal and child health, sexual and reproductive health, and health equity, with a focus on examining how social and structural drivers affect health outcomes. Her research interests are rooted in collaborating with community partners to address health disparities through community-engaged research. Welcome, and thank you for joining us today, Jill. Next, we welcome Dr. Tiwaladeoluwa. Dr. Adekunle is an assistant professor in reproductive and population health in UW-Madison's School of Medicine and Public Health Department of Obstetrics and Gynecology, where she was awarded the Anna J. Cooper Fellowship for incoming faculty. Her research draws from communication studies, public health, and disability studies to design and lead community-driven projects that identify barriers to perinatal well-being, improve obstetric care, and support better health outcomes. Welcome, and thank you for joining us today, Tiwaladeoluwa. And lastly, we welcome Dr. Zoua Vang. Dr. Vang is the founding director of the Maternal Child Health Equity and Safety Lab at UW-Madison. She is also the Meta Schroeder Beckner Outreach Professor and holds a joint appointment as a professor of civil society and community studies in the School of Human Ecology, and as an integrated specialist at the UW Division of Extension's Health and Wellbeing Institute. Trained as a mixed method researcher, Dr. Vang uses both qualitative, quantitative, and participatory methods in her studies. Dr. Vang is affiliated with the Division of Reproductive and Population Health the Department of Obstetrics and Gynecology, and the Institute for Research on Poverty at UW-Madison. She's also an adjunct professor in the Department of Obstetrics and Gynecology at McGill University, an investigator at the Research Institute of the McGill University Health Center. Welcome and thank you for joining us today, Zoua. I am now pleased to welcome Niti as our moderator. Let's begin today's discussion.
Thanks so much, Kaylin. Hi, everyone. My name is Katie Newcomb. I'm the Communications Director here at GHI. Unfortunately, we've lost our connection with Niti. She is in India. We are going to hope that she can come back on and join us. So that said, I think we will keep our fingers crossed and I will let her in when she's able. So in that case, I think we'll head right into our first panelist. So Jill, if you don't mind getting started, we welcome you.
Thank you so much. Good morning. I'm happy to be here this morning to discuss community-driven solutions to justice-involved maternal health disparities. Oops, sorry about that. I'm an assistant professor at the University of Wisconsin School of Medicine and Public Health and director of the UW Prevention Research Center. The aims of the Prevention Research Center are to improve the health of women and birthing people, infants, and families impacted by health inequities by conducting and building capacity for prevention research rooted in health equity. We engage researchers, public health practitioners, community members, and translational partners in community-engaged prevention research. We also support community engagement, research, evaluation, and translation. We became involved with examining the experience of justice-involved people when a member of the community reached out to us. This community member had the experience of being pregnant. She had a substance use disorder. And once of learning about her pregnancy, she went to her doctor and was legally prescribed and monitored medicated assisted therapy in the form of Suboxone. She was on probation at the time and shared this with her probation officer, who revocated her probation status and put her in prison, where she remained until her baby was 5 months old. Through this experience with this community member who was really very much an advocate, wanting to understand health outcomes for both birthing people and infants, we began this journey of working with various community members to examine the experience of justice-involved birthing people. I want to briefly ground incarceration in the U.S. and specifically in Wisconsin for you. I am comparing the U.S. with other NATO countries, so countries that are similar to the U.S. As you can see, the United States out incarcerates other countries by large margins. Then when we look specifically at Wisconsin, Wisconsin is right up there with the United States, out incarcerating as just a state, out incarcerating several countries. When we look at disparity by race, in Wisconsin, the general population is 80% white, 6% Black, and 1% Native American. Yet when we look at the jail and prison populations, the population is 50% white, 46% Black, and 5% Native American, which is a glaring racial disparity. Men still are incarcerated much more than women. As you can see, the blue tiles are the women, and the goldish tiles are men that are incarcerated in Wisconsin. Again, when we look at and we compare ourselves, this is just the state of Wisconsin and women who are incarcerated with countries. Again, we grossly outnumber countries as a state on the number of women who are incarcerated. I want to bring your attention to the increase of women incarcerated in the U.S. Since the 1970s, that number has continued to increase. And the green line, which represents the increase of women being incarcerated both nationally and in Wisconsin in the rural areas. So that is a new phenomenon, fairly new phenomenon, and it continues to increase. There is a noticeable decrease during the COVID-19 period, both nationally and in Wisconsin incarceration. Okay, women, as I stated before, Wisconsin incarcerates women at higher rates than almost every NATO country. Black women are incarcerated at nearly twice the rate of white women. And the majority of women who are incarcerated are of reproductive age, which is 15 to 45 years old. I do want to point out that there are more white women who are incarcerated and that the number continues to increase at a greater rate than other races. But the disparity by race currently continues. Why are women incarcerated? Due to substance use disorder, mental health disorders, economic insecurity, domestic violence. Usually they are the victim of the domestic violence dispute, and then over-policing in racialized communities. Approximately 55,000 pregnant women are incarcerated at some point during their pregnancy in the U.S. Incarcerated women are significantly more likely to have risk factors known to negatively impact maternal and infant health outcomes, such as infectious disease, mental illness, substance use disorder, and cognitive disability, as compared to men who are incarcerated and women who are not incarcerated. There is no Wisconsin Department of Corrections pregnancy outcome data on the numbers of maternal deaths, live, aborted, or stillborn pregnancies. There has been attempts in the past to garner this information, and in 2016, a researcher was able to capture some point in time data from one of the 3 state prisons housing pregnant women. We aim to fill gaps in research related to justice among birthing people. Here are a few of our related projects. A co-designed doula project for justice involved pregnant and postpartum people. The goal was to identify how to provide and sustain high-quality, comprehensive perinatal care that preserves continuity of perinatal care for persons in Wisconsin jails and prisons. We used group concept mapping and focus groups. Our participants were people who were pregnant at some point during their pregnancy in a Wisconsin jail or prison, community doulas, and community peer support specialists. The community helped develop research questions, recruit participants, and analyze data. We held groups in person in Milwaukee, Madison, and virtually to generate more geographical representation. Our initial results from the group concept mapping garnered 5 statements rated as being most important for health and the most feasible to implement. Education for birthing persons' needs and supports, basic program principles, doulas' roles and responsibility, training for doulas and prison and jail staff. It was also community members who helped us to understand that we needed to expand our original thinking and reach out to those on probation and parole and not just focus on those who are or currently institutionalized. Where do the babies go? Infants of incarcerated mothers and their caregivers. Wisconsin does not have a prison nursery. After birthing, people give birth in the community that's closest to their institution. They have 24 or 48 hours to be with their baby. Then they go back to their institution where they're being housed. and then the baby has to go somewhere to be cared for in the community. The goal of this research was to examine the lived experiences of birthing people who had babies while they were incarcerated and the people who cared for the babies after they were born, and to really understand the experience of placement for the babies during that first year of life. We used semi-structured interviews and conducted surveys. And we had 12 women who had had this experience and 8 caregivers. This was a heavily involved community engaged programs. We had many community programs from community organizations and just lay people from the community. We had a project community advisory board made up of people with lived experience of being pregnant while incarcerated, or being caring for a baby while somebody was incarcerated. We also had a technical advisory board made up of professionals who served the population. The project community advisory board and technical advisory board helped develop research questions. They helped with survey development and with forming meaningful interview questions. As previously noted, there are many reasons that birthing people are incarcerated that put them on the path of interacting with law enforcement and the criminal justice system, which is why in our next study, we examine the intersections of maternal mortality and the criminal justice system. We analyze Maria data. The Maria database is a CDC, Center of Disease Control database that maternal mortality teams across the nation use to input data in and to make recommendations. I am a member of the Wisconsin Maternal Mortality team. Our team is made up of a diverse interdisciplinary professionals that review maternal deaths. Maternal death is indicated when a birthing person dies during pregnancy or up to 364 days postpartum. As a member of the Wisconsin Maternal Mortality team, I wanted to look at the intersections of maternal mortality and the criminal justice system and possible areas where interventions could have prevented deaths. Thank you so much for your time. Please click the QR code to stay in touch with our work. Thank you so much, and I will pass it back to Niti.
Thank you, Jill. Thank you for sharing these experiences and research with us. I think, maternal health disparities and incarceration are very closely related, because that is one situation where disparities kind of accentuate the lived experiences of women. So thank you so much for that. I'd like to draw to Callan to ask if I could go through my presentation before I call upon Tiwalade,
Yes.
or should we do all the speakers first?
I think that's fine, Niti. Please go ahead.
Okay, I'm so sorry I lost connectivity, and the order of the webinar was. Is my screen visible?
Not yet.
Let me just try once more. Now?
Yes, looks good.
Oh no, but this is the last slide. Just give me a moment. Yep.
So Niti, I can always help share your slides as well if that would work better for you.
Thank you, Katie. I'll just give it a last try and then I'll request you.
Okay, sounds good.
Thank you. Yeah. Is it working now?
Right now we see your screen. Yep, looks great. Thanks, Niti.
Okay, great. So, hi everyone. Sorry for the delayed introduction, but I'm Niti and I am representing SM Sehgal Foundation here. Just to begin with a brief background of the work that we undertake at the foundation and my representation. We are a grassroots interventionist organization based in India. We are 26 years old and are mandated totally to rural development. Our focus is on empowering rural citizenry through various flagship programs that we have on the ground, including agriculture development, water management, local participation and sustainability, and transform lives one school at a time. The focus is more of an integrated development. We feel that agriculture is very closely related to water. Capacity building of citizens is very important to sustain the interventions that we have in agriculture and water. And of course, education anchors all these developments as we move, as we try and progress in any societal context. However, two things that actually cut across all these four flagship programs that I mentioned are climate change, because we all know that climate adversities are affecting all the outcomes, especially from a development perspective. Besides climate change, one thing that I'd like to flag here is that women's empowerment for us is a cross-cutting theme. And that is the very reason why I'm here, because women's empowerment is deeply interwoven through our experience of more than 2 decades. We have realized that empowerment of women is deeply interwoven with all the interventional outcomes that we are seeking on the ground, especially in rural India. Given that our focus is totally rural, I'll place my emphasis there. But having said so, outcomes on or sustainability of any development outcome totally depends upon how women are a part of that entire process. And therefore, women's empowerment is an integral part of the foundation's work. Coming to the focus of the webinar, just to kind of set up a context, I know Jill has already spoken and she actually addressed a very, very important aspect of maternal health disparities. But let me just take a step back and talk about the global trends. We all, globally, there is a commitment through the Sustainable Development Goals on improving maternal health outcomes, improving overall well-being of the populations through SDG number 3, with a specific indicator looking at maternal deaths, reduction in maternal deaths. But we see that there has been incredible progress on that SDG, not that there hasn't been. But when we delve into, the greater data details, we realize that there are stark inter and intra-regional inequities. And why do I say that? Is because, if you look at the global data, regionally, we see that almost 87% of the maternal deaths continue to be localized in sub-Saharan Africa and South Asia. But within sub-Saharan Africa also, there are countries that are doing better, like Rwanda, but there are other countries, other counterparts in the same region that are way behind in terms of achieving the SDG goal. So there are stark inter and intra-regional inequities. Plus, what we are noticing now through the data trends is that in 2023, there was a humongous progress in terms of reduction of maternal deaths. But come 2025, that progress has slowed down considerably. And of course, factors like COVID, health shocks like COVID, of course, decelerated the entire process. Or more than deceleration, there was also regression. So we have to see that the inequities that exist globally, intra-regionally, inter-regionally, have to be identified. Jill addressed some of those, highlighted some of those. Access to quality care, of course, there are disparities based on the region, based on the geography, based on even the dichotomy of rural and urban can accentuate the disparities that exist. Then, of course, funding gaps is another thing, with the recent change, shift in the funding scenario across the globe. There have been places which were requiring a lot of intervention but are no longer receiving the kind of support they need. Coming now, closing, narrowing or funneling down to some of the validated models that Sehgal Foundation has tested in Indian context, and maybe these could be replicable in other contexts, of course, through customization, includes that how women and men as a society, they kind of integrally form the reasons or the major factors in how development outcomes are achieved. So as I say that, I clearly remember one example when I was doing one of the evaluations. Empowering women solely in any context would not be enough, would not sustain if the men are not coming along. So if you empower women to talk, if you empower women to move out of their homes, access their rights, access health facilities, they won't be sustainable if the men don't come happen simultaneously. So that's a very, very foundational premise, that we have to kind of look at when we are talking about development interventions. The list here basically, demonstrates some of these tools and mechanisms and models that we have tested over time, which include, training women leaders. We have these small institutions that we've built called women leadership schools, which are basically small, informal gatherings of women who are interested in driving change at the ground level. We bring them together, we train them on several things, balanced diet, nutritional outcomes, government schemes and policies that they can access and take help from, and how they drive that secondary change when they go back to their villages, how they drive that forward. Behavior change campaigns, as I mentioned, that it takes a society to basically improve maternal health outcomes, or even for that matter, any development outcome. Then nutrition related interventions, of course, form one of the most important subsets, especially in rural India, where we see that, diet diversity is a big problem. Illiteracy plagues the understanding of having a balanced diet, how simple tools can help women understand diet diversity, different colors on the food plate, and how this can lead to improved health outcomes and nutrition outcomes for women and for children. Then revamping local health systems. There are community celebrations, like we do a Poshan Maha, we call it. That's a Hindi word. I'll tell you, it basically means a nutrition month. So what we do is, for the entire month, we celebrate each, or one food item. Maybe every day we go to the communities, we talk about how those food items are very important to add protein, add carbs, add vitamins, minerals, and talk about that food pyramid. Then uptake of maternal services and community monitoring. Now, community monitoring, when we talk about community initiatives, it is very important that while the services may be doing their best, but if there's no community monitoring, then of course, the momentum sometimes becomes very complacent. Or there is, when the population, India grapples with a huge population. So that also kind of comes together if the community is proactive in driving that change. So I'll end here. I just wanted to set up a context of how community-led models or community-led tools, simple things like women leadership schools, or just having a congregation of women could help transform that entire maternal health outcome data, especially in rural contexts. And I hope that people could emulate some of these or customize some of these models into their context and see their applicability. So thank you so much for that. I would now request Tiwaladeoluwa, if you could take us through our presentation. Thank you.
Thank you so much, Niti. I'll go ahead and share my screen. Okay. Are we seeing my screen?
Yes.
Thank you. Yeah, hello everyone. It's an honor to be here with you all to present my research this morning. I recently joined the OBGYN department at University of Wisconsin as an undergraduate Cooper Fellow and incoming assistant professor. Today I'll be sharing more about a project that explores Black women in the U.S. perspectives of and responses to pregnancy risk within the context of the ongoing Black maternal health crisis in the United States. So this project was supported by the Waterhouse Family Institute at Villanova University, and I have no conflicts of interest to disclose. So as we've already established this morning, there's a lot of problems and issues with maternal health around the world, but also within the United States. So one of the most striking statistics that demonstrate this is with maternal mortality and looking at the maternal mortality disparity between Black women and white women in the United States. So this issue of the maternal health crisis here in the US has risen to the level of not just requiring academic or research attention, but also attention in the media as well. And it's reached the realm of public concern, and it dominates a lot of public narratives leading to headlines like the one that we see on the right. So what brought me into this project initially and into this space was just a desire to understand from the community's perspective how people interpret their own risks during pregnancy and what that means for how they approach the pregnancy process, for their participation in their healthcare, as well as for the decisions that they make throughout pregnancy to keep themselves and their newborns safe. So in addition to that, this project was informed by the social amplification of risk framework, which really describes how risk is determined by social and cultural processes, which means that an expert cannot convey risk to a layperson, or a doctor couldn't convey risk to a patient, etc. It really is a subjective construct that is informed by a lot of different processes within society. The research questions that I will go into today were how do Black women perceive pregnancy risk and how do Black women enact agency in response to pregnancy risk. So both interested in the idea of people's perceptions, but also the community's own agency in response to risk. So for this study, there were 28 self-identified Black women who were either currently, recently, or planning to become pregnant. There was representation across several states within the US and across different professions, but I will say the majority of participants for this study had higher levels of education, which I think is reflected in some of the actions that people took in terms of self-protective decision-making. And so now I'm going to share just a little bit about the main findings that we derived from this study. So a thematic analysis of in-depth interviews with Black women reviewed several themes within two main domains of what are the main domains of risk perception and what are the self-protective responses. So focusing primarily on domains of risk perception, Black women talked about healthcare as being both safe and dangerous. They expressed concern for their lives and the well-being of themselves, as well as concern for their health and the well-being of the baby or the fetus. In terms of their self-protective responses, there's a lot of people conducting in-depth research and engaging in self-advocacy, a lot of intentional decision-making that was being done, and a lot of selective participation, which I will explain what that meant. So now I'll talk more about the domains of risk perception. So firstly, the idea that healthcare was perceived as simultaneously safe yet dangerous. There was sort of this tension in people understanding that going to a doctor, seeing a doctor, being in a hospital means that I am increasing the potential of things going well for myself, and I am more likely to be safe. For example, this participant said, I am pretty sure they will let me know if something is wrong. Yet at the same time, in the same vein, this participant also shared, doctors don't like Black people. So there was sort of this tension of knowing that healthcare was sort of a safe place to be, and it's better to have the technical expertise of healthcare providers, but at the same time, this anticipation of poor treatment, and a lot of this was steeped in either actual or anticipated obstetric racism that Black women were experiencing or expecting to experience. And so they kind of held both of these opposing dynamics in the same hand, in the same breath. And so I'm going to read a few quotes that also illustrate this. This participant said, "For both of my labors, I stayed at home as long as possible so that I could decrease the amount of time that I spent in the hospital. I didn't want to be pressured into doing things that I didn't want to do with my birth plan." So this idea of the longer someone stays within healthcare space or the clinical space, the more likely they are to be pressured or coerced into doing something they don't want to do. This other quote, this participant said the only concern for her was if she would be able to make a choice of experiencing natural birth. And so I think the idea that that choice would be taken away so shows some of the dangers that people anticipated within healthcare. This is a bit of a longer quote that shows, I think, an incident that rises to the point of obstetric violence. This particular participant turned down an epidural, and when she did so, felt like she was being punished by her provider for making that decision. So she said, when I had the baby, that she had tears, and he was trying to do stitches on her after the tears, and didn't give her any anesthetics before doing that, and was just sewing her up without any pain relief. And she was yelling and letting him know that she was in so much pain. And then she says, what he could say was that that's why he was telling me to take an epidural, that if I had taken the epidural, I wouldn't feel this pain. So we can see here again the dangers that people were either anticipating or had actually experienced within healthcare spaces, despite the idea that these spaces are overall somewhat safe. So next, we're going to talk about concern for life and well-being of self, and this had more to do with a person's physical health, the impact that pregnancy might have on the body and the threat that it poses to life, mental health, and the impact that pregnancy might have on career and education. So in terms of physical health, a lot of Black women were really concerned about the statistics and narratives around pregnancy just because of their race. And so this was a very racialized fear of death that a lot of participants expressed. So for example, this participant said that she was scared when she was pregnant, that she thought she would die. She thought her baby would die. She had heard so many horror stories about people having terrible experiences during their labor, and she was afraid that she would experience the same thing. Outside of that, people were also naturally concerned for the well-being of their baby or the fetus. They were concerned about the healthy development of their fetus, especially if they had family histories of developmental conditions. Also concerned about the safety of their child after birth. The participant said that, and this particular participant had lived in a neighborhood that she described as unsafe. So she expressed concerns and fears about the child growing up in this, what she called, endangered environment. So now that I've covered a little bit about the domains of risk perception, a really key piece of this study for me was how does the community enact agency in response to risk? And so we wanted to know what are some of the actions people take to protect themselves. So one was research and self-advocacy, which I think is, as I said in the beginning, kind of reflected in or informed by just how well educated a lot of these Black women were that were interviewed for this study. This participant said that she read scholarly articles on medications and best practices and did a lot of literature reviews on her own to read about side effects and what's been done, what's evidence-based. And this was not uncommon. A lot of participants were doing really in-depth research beyond what I would consider to be just a normal, natural interest in care practices and best practices in general during pregnancy. So that was a big part of enactment of agency. Next, a lot of participants expressed interest in having Black female doctors and wanting that racial and gender concordance with the healthcare providers. This participant said, knowing just the horrible stats that Black women have, I want you to understand and see this as a life or death thing. This isn't just about like, oh, they have a good personality and something, like they're competent. Yes, but I also need me and my baby to be alive. I didn't even want to take a chance. So let me go out and seek a Black provider so that at least I have the comfort to say, okay, she gets it. She understands it. She will listen to me. So this selective participation piece was something that was that came through for people who had really high levels of mistrust in healthcare. This person that said, don't give me medication. You may give me something to like harm me so you can operate on me to get whatever you may need from me. So she had a lot of mistrust in her healthcare provider, and that informed her decision to not adhere to a lot of the recommendations she was given, and in some cases also not communicate certain things to the doctor. And this was something we saw with people that had particularly high levels of mistrust. Another important piece, and that's really relevant to our conversation today, is the idea that Black women were utilizing or expressing the desire to utilize community-rooted support. So part of that was through doulas. A lot of participants expressed the desire to have a doula there to sort of mitigate what they felt was the danger that they might experience in these healthcare spaces. So like this participant said, having somebody plugged into the pregnancy experience who was there for the sake of being sure that we're okay. It's not my mom, it's not his mom or anything like that. The doula is here to be sure that we're fine. So this is something that a lot of participants expressed, that desire to have a doula, who are doulas or community-based providers present in their pregnancy process and care. Peer networks were also really important. A lot of people used their peer networks as a protective mechanism as well to mitigate the dangers of and risks of pregnancy. So this particular participant had lost trust in her care team, and so instead she relied on her sorority sisters, and she said she knew that she says, I know health-wise, they were my doctors to me. Like they were my doctors. I was sending them, this is what my blood pressure was like. I was sending them the stuff. I didn't really care what my team had to say at that point. So I feel like they helped me get through. So again, that idea of really leaning on community support, whether that's through community-based providers like doulas or through one's own networks. So just as some takeaways from this project in terms of the importance of community-driven solutions. One, it's important to know that Black women are cognizant of and responsive to the heightened dangers they face during pregnancy. A lot of this really is made necessary. A lot of these responses are made necessary by the maternal health disparities and obstetric racism that Black women either experience or anticipate experiencing. And foregrounding the community's voice in this way really exposes the toll that disparities take, even for individuals who are not yet pregnant and are only planning to become pregnant. There's a psychological toll of like the threat that they think the pregnancy might pose to their lives or their infants. In emphasizing the importance of doulas, of midwives, and their own peer support networks in navigating risk, the study also underscores the need for interventions that leverage community strengths for Black women. And that is all I'm going to share today. Thank you all so much.
Thank you, Tiwalade. Thank you so much for simplifying how women perceive health risks and how disparities, interfere with their agency. The quotes actually that you presented in verbatim, they highlighted the essence of how our lived experiences may not reflect in a data point, but are of immense value. So thank you so much. I'd now request Zoua if you could take us through our presentation.
Thank you, Niti. Let's see here. Okay. Are you able to see my slides?
Yes.
Yes.
Okay, great. I'm gonna go from the start here. So thank you, everybody. A lot of the themes that I'm going to cover have also been discussed by both Jill and Tiwalade. And so I'm just going to give some examples from a couple of my studies that have been ongoing. And before I do that, though, I wanted to position myself vis-a-vis the work that I'll be sharing this morning to give you some larger context into my role as a researcher and the different communities that I'm partnering with in the work that I and my teams do. So I am, this here is a old picture of my parents and myself here in this little red dress with my younger sister and my cousin Ba. And this is a picture of us in a Thai refugee camp cornfield. I was about 4 years old here. And so I like showing this picture because it nicely and succinctly summarizes my life experiences as a racialized 1.5 generation Hmong refugee. But what this picture also doesn't show is the additional dimensions of my social identity and positionality as a settler of color, as an American, and also as a Canadian, and as a community engaged scholar who focuses on social determinants of health in partnership with different underserved communities to achieve health equity. And so the work that I'll be sharing this morning really brings to the fore how my own positionality and lived experiences have heavily influenced the projects I choose to engage in. Let's see here. So before I dive into some of the examples from my studies, I wanted to position the conversation a little bit in the talking about culture, and in particular the role of culture in health and healthcare. So typically when you hear the word culture, especially in the health context, we typically think of language barriers that patients of other cultures bring to the fore as they navigate the healthcare system. We can also think of different practices, beliefs, or values of our patient populations, and typically we think of these practices, beliefs, and values as belonging to others, and meaning ethnic, religious, and racial minorities. Okay. And often we don't think about how Western biomedicine itself has a particular culture embedded in, European white cultural roots, and how that permeates our healthcare system, especially in North America, and influences the kinds of procedures, communication styles, and understandings of disease and treatments that we offer patients in our healthcare system that may not necessarily be incongruent with the beliefs and practices of diverse other cultural groups. Okay, and so I mentioned this in part because when we hear about culture in the context of healthcare, we focus on these cultural others, and we often leave invisible our own cultural biases that permeate our healthcare practices. Okay. And yet we know that culture, whether it's the dominant culture or minority cultures, affect the way that we perceive disease etiology. They also influence the way different people express illness, especially in the case of mental illness, for instance. So there's different idioms of distress across different cultural groups for the same phenomena, such as depression. It also influences our help-seeking behavior. So whether, how, and who and where we seek care when we are in need of healing. And finally, it also influences the different kinds of treatment options, the progression of the options, and the effectiveness of these different treatments that are given to patients. Okay, so culture really is embedded in healthcare itself, or our health, and should be embedded in our healthcare. But in the way that our current Western biomedical model of care is implemented, culture is often not taken into consideration, and especially the culture of diverse others. Although our own cultural, Eurocentric Western cultural norms are deeply embedded in the current biomedical models of care. Okay. So what I'm trying to argue here is that alleviating health disparities in maternal and child health requires taking culture into consideration as well too. Okay, and integrating that into the way that we deliver care for our mothers and children. And so the goal here is not to replace the current biomedical models of care, but rather to complement them with services that are more culturally appropriate. And so community-based strategies are one way in which we can try to integrate culture to achieve this goal of providing more complementary services that meet the needs of diverse cultural groups. So I'm going to share a couple of projects where we are using community-based approaches to try to address the role of culture, but also to try to provide services and increase access to underserved populations. So one study is focused on refugees. And as many of us know, working with refugees in the context of maternal child health, but any health issues really, is quite challenging, in part because the health issues that they experience are quite complex, related to their situations of displacement, trauma, and the many resettlement challenges that they experience in the countries that host them, right? So we know that refugee women and girls have a disproportionately higher risk of poor reproductive and perinatal health, including severe maternal morbidity. And community health workers have been a evidence-based, community-based approach that has been shown mostly in low and middle income countries to be an effective strategy to increase access to maternal child health care, but also to improve outcomes for moms and children. Community health workers strengthen the patient-provider relationship. They reduce patient's health risk, okay? And then they also improve proper healthcare usage, but just as importantly, they provide important sources of social support for women and their families. So you heard this morning about doulas being really important for a community-based approach for Black women in the United States and Wisconsin. And doulas could be considered part of the spectrum of community health workers that exist out there. Okay. So one of our studies with colleagues listed here focuses on refugees in Wisconsin. And here we trained 3 community health workers from the Afghan, Congolese, and Rohingya communities in Appleton, Madison, and Milwaukee to provide group and one-on-one non-clinical services and supports to pregnant and postpartum women from these 3 refugee populations. And these 3 populations were chosen because these are the 3 largest groups of refugees in the state. Okay, so here we're really focusing on outcomes, including healthcare access, improving health knowledge, and ultimately in the long term, hoping to improve maternal and child health among these 3 refugee groups. And to illustrate the importance of community health workers as a community-based strategy, really community health workers are both cultural brokers, but also cultural insiders as well too, right? So in other words, they're aware of what's happening in their communities and are best equipped to address community needs as they arise. So in our work, for example, one of our group sessions with Afghan women here in Madison, the Afghan community health worker organized and co-facilitated a session focusing on self-care and mental health, but it wasn't called mental health per se. It was simply a group session where women came together to have tea and cookies. And the discussion was co-facilitated by the Afghan community health worker as well as a mental health expert on our team. And this session was deemed as needed by the community health worker because of an event that occurred in Afghanistan, which prevented families here in Wisconsin from knowing what's happening in Afghanistan. Communication channels went down, everything went black, and families were really worried about their relatives and friends in Afghanistan. And so without this insider knowledge that was brought forth by our community health worker, we would not know that this major event was happening in the community that was causing such distress. And so by her bringing this to our attention and leading this co-facilitation of this session for the women, we were able to provide some means of support to women during this difficult time. So that's just an example. Another example comes from another project. So I have been working with Inuit communities in Arctic Canada for the past 10 years. And in northern and remote regions such as the Arctic, healthcare access is quite limited. So typically, the model of care is a fly-in and fly-out model, meaning that healthcare practitioners are flown into the Arctic from southern cities such as Winnipeg, Montreal, Vancouver, and patients in the Arctic are flown out to the for care in the south. Okay, so even childbirth is included in this fly-in and fly-out model. sorry, just checking the time to make sure I'm not over. Okay, I'm almost over. Sorry. So I'm going to quickly wrap up here. So there are pronounced disparities in maternal and child health outcomes. And here I have two projects. We're focusing on different regions of the Canadian Arctic, where we are integrating community-based approaches to provide services for pregnant women and their families. So in one study here in Arctic Quebec, we are providing culturally appropriate psychosocial supports through elder supports, providing for them while they come to Montreal for care. And in another project in Arvia at Nunavut, what we're doing there is trying to advocate for the expansion of midwifery, and specifically Inuit-led midwifery as a sustainable, culturally safe approach to keeping women in the communities for childbirth. So, with the interest of time, I will stop there.
Thank you, Zoua. Thank you so much. Your presentation actually highlights how socio-cultural factors permeate into our perceptions and practices, and also how they greatly influence our agency to access healthcare. So, we are at the tail end of the webinar. We have requested the participants to ask questions, and we have a couple of them here. So, I think I'll take the most recent one. This is for Tiwalade. Tiwalade, an attendee asks that how do you think that health systems and public health practitioners can leverage the strong community network that exists among pregnant African Americans to reduce maternal mortality rates? It'll be great if you could just keep it brief. Thank you.
Absolutely. I think the first step is really sustained engagement. I think engagement that happens before there is a problem, and then that continues beyond that. So finding ways to really create platforms where that can continue to happen and health systems can continue to engage on a consistent basis and really build that trust. I think that would really help move the needle forward.
Appreciate. Thank you. Just one more question. An attendee asks, I think this is addressed to all the speakers. If we wanted to support efforts here in Madison, what opportunities are there, or who should we reach out to? Especially interested to see how I could support using French language skills. Any speaker would like to address that? An attendee wants to reach out for help, basically to help the efforts here in Madison. So, Zoua, Jill, Tiwalade, any insight on that?
I think there's always local organizations already doing some amazing work supporting especially refugee communities. And certainly in some of these refugee communities from French-speaking parts of sub-Saharan Africa, for instance, many of the Congolese participants that we work with in our project speak French, although it's not the preferred because of the colonial history, but it is a language of communication that can be used. And so I would recommend reaching out to local agencies like Jewish social services or, Catholic Multicultural Center for those kinds of volunteer opportunities.
Great. Thank you, Zoua. Okay, that brings us to the conclusion of the webinar. Thank you to the participants. Of course, I'm going to give it to Calin, but before that, I just want to wind up the entire and consolidate the entire webinar. I think a brilliant collection of our speakers, some an action research perspective, an implementers perspective, researchers perspective, all put together, of course, highlights how communities play an immense role in, addressing factors that emanate out of the cultural, geopolitical, situational, context that we kind of operate in, that we come from. So thank you, each one of you, to share and, also attach it to your personal lives and lived experiences. Thank you so much. Over to you, Calin.
Great, wonderful. Thank you. And thank you all. What a wonderful discussion today. Unfortunately, that is all we have time for. Please join me in thanking our esteemed panelists for sharing their invaluable insights and perspectives today. I'd also like to thank all of you for joining and sharing your comments during the discussion. Be sure to visit our website, ghi.wisc.edu, to learn more about our upcoming webinars and find today's archived video. Our next webinar is on Tuesday, November 18th at 9 a.m. Central, where our panel will explore AI's potential to address global One Health crises. Thank you, everyone, and I hope you have a great rest of your day.